I'm the Executive Director for the Virginia Association for Hospices and Palliative Care, and I am delighted to be here. I have been a hospice nurse since the 80s, so I have seen the birth of palliative care and have enjoyed every minute of it. It's doing wonderful work, and I am delighted to be here. As Diane said in the earlier session, not everybody who needs palliative care is over 65. And our panel this morning is going to look at the palliative care principles across the age spectrum. And our first two speakers are a pair of pediatric nurses. They're bi-coastal. One is from Maryland and one is from the Pacific Northwest, and they have worked together on many occasions. And so I'm going to let them introduce themselves. You can read all about them in your agenda. So Deborah and Kathy, over to you.
Hi, I'm so happy to be here and to share our passion with you today. I'm Debbie Lafond. I'm actually a nurse practitioner here in Washington, D.C. at Children's National and one of the co-directors of our PANDA palliative care team.
And I'm Kathy Perko. I'm also a nurse practitioner, and I'm from Portland, Oregon, and I am the director of our pediatric palliative care program, which is called Bridges. So we are going to spend the next, hopefully, 20 minutes or so talking to you a little bit about pediatric palliative care. And one of our goals at the end of our talk is that when someone talks about palliative care in the future, when you talk about palliative care, you remember that it starts with the preborn. And it goes up through the toddlers and the school-age kids, the adolescents and the young adults. And if you come away with nothing else than that, I think we will consider ourselves a success. So our objectives are to talk a little bit about what is pediatric palliative care, how is it different from adult palliative care, some of the challenges that we have seen over the growth of our programs. Then we're both going to talk a little bit about how our programs work, and then again circle back to sort of look at the future and how we can continue to improve the care of children and their families through palliative care. So first, let's talk about why does this matter? So only 1.6% of the total deaths in the United States are from our children, which is a very small number. And that is also noted by the fact that there's no term for a parent that has lost their child. You can be a widow, you can be a widower, but there's no word that we have that describes a parent that has lost their child. So although it's a small number, it's a significant number, and it's life-changing for those families. About 43,000 kids die a year. Half of those are infants, and half of those infants die within the first 30 days of life, which speaks back to a little bit, which we'll talk about again, about technology. We can do lots of things to save lives, but what does that mean for families? How young a baby can we save and have a quality of life? Additionally, about 5,000 kids every day today are nearing the end of their life, and those kids have chronic complex conditions. 400,000 kids in the United States have chronic healthcare conditions. These are kids with cystic fibrosis, Duchenne's muscular dystrophy, kids with cancer, which is, I think, is something we think of often, premature babies that have a lifetime of chronic illnesses, kids with congenital heart disease, children with cerebral palsy, who, although their brains work beautifully, their bodies don't, and we have to support them through good symptom management with something as simple as a child that goes to school needs a set of books at school and a set of books at home so that they don't have to move their books back and forth. That's palliative care for kids. So it's not always about end-of-life care and pain and symptom management. It's how do we meet these families where they are and then help these families go through this process. It does account for about a third of our healthcare spending when we look at pediatrics generally. These are the kids that are seen just like the adults, more often in the emergency room. They have long hospitalizations, and they come back again and again. And we believe, and we have seen with good palliative care, we can decrease those hospital admissions, we can decrease those ED visits, and we can keep those kids at home where they want to be and where their families want them to be. So this is just a snapshot of the types of kids that we care for and the reason that children die. This also exemplifies the breadth of knowledge that pediatric palliative care teams, interdisciplinary teams, need to know about. So we're looking at premature babies, congenital heart disease, neuromuscular conditions, accidents, failed suicides for these kids as we look at this lifespan from pre-birth up to age 20 or 21. So what is pediatric palliative care and why is it different? So our definition is not that different from Diane's, which she put up this morning. I think one of the keys to all good palliative care, but especially pediatric palliative care, is this interdisciplinary team. None of us can do this by ourselves. It's emotionally difficult. It's also a lot of knowledge that we need to have. And then we need to look at what is the difference with these kids. So kids, their work is play. So how do we allow kids to play as they're moving through their lives with these chronic conditions, as kids are nearing the end of their life? So in addition to the traditional team members, we also have child life specialists, which are an incredibly important part to help us take care of kids and also to give kids that break. And sometimes I think we laugh that a child draws a picture and we always try to make it something really monumental, and sometimes it is, but sometimes it's just a picture. So they really help us sort of balance that piece of, I'm just drawing a picture because it's been raining in Portland for 3 months and I'm tired of the rain, versus the rain is about being sad and being worried. So they help us, our psychologist colleagues help us as well to sort of help look at the whole picture. And then always, no matter what age the child is, it's always about good quality of life. We want every child, every infant, every family to have this day be the best day that they can have. So what are those differences? So Debbie and I were saying that we did a presentation recently where we had, like, I think 3 pages worth of differences between pediatric and adult palliative care. But we sort of summarized it in this way that hopefully everyone in this room has an advance directive, and if you don't, then you were thinking about having an advance directive. We are responsible for our own health care as adults, and so we talk about formal advanced care planning. With kids, we don't do that. Who's making their decision? Well, their parent is, but then they get older. What about the 15-year-old? How are we addressing their needs? How are we talking to them? How do we engage the parent, so the family, sometimes it's a grandparent, and the child to look at advanced care planning? And then this increased use of technology in pediatrics. So I have been a nurse for 30 or so years. And when I was first a nurse, a baby that was born at maybe 26 weeks, maybe 25 weeks of pregnancy was considered the tiniest baby you could care for. Babies that were born before that were not viable. We have a baby in our intensive care unit right now that was born at 23 weeks and 5 days. They're a set of twins. They're now 5 weeks old, and they're doing remarkably well. So we've moved that this way. But now we have some of these kids that go home with trachs, with ventilators, with G-tubes that need a lot of complex care. And what are we asking their families to do? We're asking them to do that care. So we have palliative care, we have some home care, but we're asking families to do more and more with their children because of the things that we have done to increase the technology. It's not right or wrong. It's a family decision, and it's different for every child. And then developmentally, that's a big difference. So I'm going to assume in this room that we all know if I tell you that you're dying, that that's permanent. You're not coming back. It's the end of your life. Kids aren't like that. If you can have a 5-year-old that's sick, a 3-year-old brother, an 8-year-old sister, and a 12-year-old sister, all of those kids look at death differently. They all have a different way of seeing, is death permanent? Am I going to come back? Is it, I think it's safe in this room because there's enough people my age-ish, that the Roadrunner cartoons, where the Roadrunner would die and jump off a cliff and die, and then after the commercial break, where was he? He was right back where he was before. So kids in some ages believe that. So how do we, as a team, an interdisciplinary team with our social work colleagues, our child life specialists, our nurses, our physicians, and our families, and our hospice teams that take care of these kids at home, how do we come together to really address the developmental issues of kids? So when we look at palliative care, it really is across the lifespan. And as everyone has said today, we're telling stories to sort of talk about this. So my story today is a family who actually came back, because we talk about education, who came back on Tuesday to give a lecture to our pediatric and family practice residents, also our nurses and anyone else that was available. And it's the story of Jack and Kate. So their mom, Jody, was pregnant with her 4th pregnancy. They thought they were having 1, and they got a surprise and were having 2. They had a 4-year-old, a 6-year-old, and a 7-year-old at home. She was having a regular pregnancy. Things were going along well. And at 24 weeks, she had some bleeding. So she didn't know what that bleeding was. And then because she is a mom of 3, she leaves her husband at home to take care of the older kids and drives herself to the hospital. So she drives herself there, and yes, she has some bleeding. Our team partners with the NICU team and the OB team to talk about what do you want for your babies at this time. They wanted everything done. They wanted to do as much as they could for their babies. So the babies were born 12 days later. So she got a little bit further along in her pregnancy, and it was clear within an hour of their birth that Jack was not going to survive. So here's a mama, has 2 babies. Jack is dying. Kate is alive. Their kids are coming in. So our palliative care team came together with Child Life, with social work, and arranged for that mom to go to the resuscitation room to spend that last bit of time with her son, Jack, and then spend 103 days in our NICU with Kate. And so what did we do? We provided bereavement services. We provided active care. Kate had a rocky start, as you might gather. We answered questions, and we sat next to her bedside when Jody needed someone to talk to. So today, Kate is 16 months, 12 months corrected, and she is nearly walking. She pulls up, and she is doing well. But what we did is that's what palliative care is for pediatrics. It's a family experience.
So for many years, families were forced to make a choice. They were forced to make a choice between treatments that could be potentially curative or life-prolonging, or a choice of improving quality of life by involving palliative care. We asked them to make an almost impossible choice, a choice that can be perceived as being life or death. And I can't even imagine what that must be like as a parent, to have to choose or feel like I'm choosing whether my child lives. So what were the consequences of that? Very few children were enrolled in hospice, and if they elected to enroll, it was often at the very end of their life, with a whole new set of hospice caregivers coming to the home who knew nothing about the very scared 2 or 3-year-old, didn't know anything about the family. And so they had no chance to develop a meaningful relationship with this family, and often they had to give up relationships with their primary care teams. This all changed a little bit in 2010. Prior to 2010, wasn't that we couldn't get concurrent care. It just took a lot of coordination, a lot of really talking to the insurance companies, explaining what we needed, and it was really on a case-by-case basis. But in 2010, with the Affordable Care Act, and more specifically the section on concurrent care for children, now we're able to give disease-directed treatments at the same time that we can focus on quality of life by adding palliative care early into the disease trajectory. But there's still some challenges with this. This only applies to children who have Medicaid or the CHIPS program. They have to be under the age of 21. And the physician has to certify, still has to sign that form, that they would not be surprised if this child died within the next 6 months. But they are entitled to any other services that they would get for their disease-directed therapies during that time. While there are certainly some perceived financial benefits to the concurrent care model, the most important thing is that children get to be at home, where they most want to be, with their families who love them and the friends that they want to spend time with. And it gives us continuity of care. It gives us time for the hospice to develop these relationships with patients and families, to know what is most important to them at the most vulnerable times of their lives, and to be able to help guide them and prepare them as end of life nears. So how do we build on concurrent care to optimize caring for children?
I'm going to talk to you briefly. Now I'm going to talk to you briefly about our palliative care program at Doernbecher at Oregon Health Science University. So our program started in about 2003, and it started because 2 parents came back who both had children die that told a nurse in our oncology clinic, you can do better than this. Our children died at home. We had good hospice care, but we never talked to you again. We felt a bit abandoned. So we had a group of people that got together that said, let's figure out how to do this better. And what we realized is that we needed to have some connection with our hospice, our community hospice partners. So there are very few pediatric hospices across the United States. So what do we need to do? We need to partner with our hospices that take care of adults most of the time and help them take care of kids. So we sent out a survey in 2003 that asked, to every hospice in Oregon and Southwest Washington, which is really our catchment area, and said, would you be willing to take care of kids? What would you need to take care of kids? Help us know what you need, and then we'll see what we can do. So we got those surveys back. They said they needed, not surprisingly, pain and symptom management. They wanted to know about developmental issues. They wanted to know, how do you disclose information to kids? But mostly what they wanted to know is, how do I take care of myself? I didn't go into hospice to take care of kids my kids' age or my grandkids' age. Went into hospice to take care of, with all due respect, elderly people that are dying. And so what we said was, okay, well, let's see what we can do. Those are our barriers, so what can we do? So we developed an education, a 1 to 1.5 day education program, and we went to them because we can't always ask everyone to come to the big city. So we did this program 4 times in our catchment area, having anywhere between 30 and 50 people come, interdisciplinary physicians, nurses, social workers, chaplains, some volunteers. We also did webinars the first year, a year and a half, every 8 weeks. We said, what are you talking about? What's your issue? What's hard for you? And with the grant that we received from the Cambia Health Foundation, we had some iPads that we connected with people so people could connect in their cars between visits when we did our webinars. And we said, help us know what you need and we'll try to fill that void for you. That was huge. The other piece that they needed was check-in. I need you to call me. I need to check in with you. So one of the nurses on our program, she spends the bulk of her time checking in with every nurse that's taking care of a pediatric patient within our catchment area. That's somewhere between 12 and 18 patients, but that's one of the roles of her job. She calls and says, how's it going? And it's a little bit about pain and symptom management. It's a lot about, you're doing okay. This is okay. How do I talk to the 5-year-old sibling? He asked me this the other day. So how do we connect? We connect our child life specialist with their social worker. Our chaplain talks to their chaplain. So we have this clinical expertise that comes from us to them. We sometimes talk about that as the 3-legged chair, that it really is the expertise of the parent that knows their child better than we ever will, the expertise of the hospice nurse that goes to the community because that's her or his expertise, and then the expertise of the tertiary care center, somewhere where they can call and say, this isn't working. I read about this in the book. This isn't working. What else do we do? This is complicated. This is hard. How do we help you? So now we are 14 years past that. We've learned a lot. We continue those weekly phone calls to the nurses. We continue family phone calls initially every week, and then that sometimes goes down to every other week. And how we know we're successful is when that family calls the hospice team and not us, because then they're back in their community. They're back where they're going to do their bereavement and their other support. We have less webinars because those issues have moved along. We do less telehealth, although we still do some telehealth. Parents sometimes have told us that they feel uncomfortable having us see them in their living room. We just have to honor that. We do have a yearly conference, and then the feedback that we get from parents matters. I'm going to tell a really brief story so that I don't take all of Debbie's time, but we took care of a little girl in Klamath Falls, which is southern Oregon, very rural. She's 8 years old. She went home with recurrent cancer. And her hospice team came out to see her, and she said she was having trouble sleeping. So they called my office, and thankfully I wasn't there, because if I was there, I might have prescribed a medication. So instead, that nurse and that social worker do what hospice people do best, and they asked her, why are you having trouble sleeping? Why is it so hard? And she said, oh, because I'm afraid of death. He comes into my dreams at night. And so then they said, again, the hardest and the easiest thing we do, tell me more about that. Is there anything that would help? Yeah, I think if I had a pair of angel wings that I could wear at night when I was sleeping, then I wouldn't be afraid of death anymore. So then this hospice team, without pediatric experience, got their art supplies together and made a pair of angel wings for this little girl with the help of her parents and her siblings. And then she put those wings on at night, and she was never afraid of Dr. Death again, never afraid of death again. And the other piece to this is that this is the same family that on her first day home on hospice, she said to her mom, am I going to die? And her mom said, would you like spaghetti for dinner? So to go from that to this is why pediatric palliative care and community hospice matters.
So Kathy just gave some wonderful examples of how in the West Coast they reach out to the community. But we also needed this work within our tertiary care center as well. And so what we developed is a primary palliative care approach. And what I mean by primary palliative care is equipping the bedside clinicians in the acute care setting who may have wonderful, well, they do have wonderful pediatric experience, but they really have very limited hospice and palliative care education and training. And then our adult community hospice partners who have wonderful hospice and palliative care training, but they really don't have much pediatric training. And putting them together and in a shared information model and a shared education and mentoring model so that they're learning together, they're developing a shared framework so that there is seamless care planning across settings from inpatient to outpatient to home-based care to hospice. It's a year-long program. We have 3 cohorts to date, 149 of them, all disciplines, just as Kathy mentioned. And I think that one of the most exciting things is our next cohort, which I hope to start in the fall, will reach out to our community-based primary care pediatricians. So we're drawing, and advanced practice nurses, and drawing them in as well. How do we sustain this? Well, we've had wonderful outcomes from this. We have over 92% referrals for all oncology patients now. We have automatic referrals for bone marrow transplant, for heart failure patients, for brain tumor patients, and now, just as of this week, reaching out to cystic fibrosis and the muscular dystrophy program as well. I think that one very innovative quality improvement project that came out of this is an app called My Neighborhood, which in one of the previous speakers, they showed sort of a little graphic that's very similar. So parents in real time will be able to find the resources that they need and help them to work through some of the pain and symptom management. We also have expanded our community-based hospice outreach through in-person trainings, similar to what Kathy and her team are doing, and also a lot of telehealth collaboration. So not just telehealth for checking in with a patient, but telehealth for actually mentoring that adult hospice nurse who's in the home. And we're there to role model some of the communication, brainstorm together on how we might address pain and symptom management. So why does all this even matter? Well, let me tell you the story of Justice. Justice is a 14-year-old young girl with cerebral palsy. And at the age of 6, she had a pretty significant intestinal problem where she needed to have a very significant amount, almost all of her intestines removed. And so she was on a lot of technology for feedings. And over the 2 years prior to when we saw her, her family described a diminishing quality of life for her. They described her before as being, even though she developmentally delayed, being the center of their family, smiles and giggles, and very much involved with her siblings. And over the years, they noticed that that wasn't happening anymore, that it was more bad days than good days. And this family, this mother, asked her primary medical team to have the involvement of palliative care. But what they were told is, your child's not dying, your child's not at end of life. So no, we don't think that's necessary. This is a mother who picked up the phone and said, I do think it's necessary, and I'm calling myself. And so we sat down with the medical team, we sat down with the parents, we had a very open and honest discussion about what goals of care are. And we were able to get her home with home hospice. We did a lot of the mentoring that I talked about. And Justice was able to die at home, which was wonderful. But the most important outcome of this was Mom talked about the smiles came back, the giggles came back, and she was, again, the center of her family. And so when she died, that's what the mother remembers. She doesn't remember the bad days. So I think that one of the things that we've been able to demonstrate through both of these programs is that we are able to provide seamless, coordinated care. We are able to increase education so that we can increase these conversations for advanced care planning, and that patients and families have better choices in what care is involved, that they are able to have coordinated and seamless care, and they're able to be in the setting of their choice. So we thank you from the bottom of our hearts for letting us share our passion, but most importantly, for making sure that children and their families are included in this very important conversation. Thank you.
Thank you, Debbie and Kathy.